everyone. Welcome to Problem Solved, fixing last mile engagement in healthcare. I'm Shub, and today we're diving into one of the most pressing and vexing challenges facing Medicare Advantage Stars leaders and their plans, the HOS measures in the Medicare Stars program. Our guest today is Heidi Salerno from Wallace Consulting. Heidi has deep experience working with Stars leaders and plans on their Stars strategy, working across all sides of the aisle, working for plans, as an operator, working on Stars, quality improvement, member experience, as well as experience advising plans across the Stars spectrum. Today, she's going to help us unpack what's working, what's not working, and what leaders can do to really move the needle when it comes to HOS. Heidi, welcome to the show.
Hey, thanks for having me.
Super. Heidi, for those who may not know you, can you share a bit about your background and your work at Wallace Consulting?
Yeah, absolutely. So my background's been primarily Medicare Advantage, really focused on Medicare experience. So before I joined Wallace Consulting, I spent 14 years at Cigna, really in that MA space, focused on Medicare experience, led national strategy for CAHPS and HOS. So, all things driving member engagement, provider engagement, the strategy around that, meeting those regulatory requirements. And then joined Rex's team about 2 years ago as his member experience consultant, and really been doing a lot of the same things with both national plans, local plans to improve performance in both of those STARS measures. So really enjoying it.
Tremendous experience. And so apropos. So before we dive in, what is the current challenge with the new HOS measure importance? And why is it such a hot topic today?
So definitely a hot topic. We're getting so much interest in HOS right now. And it's really because of the change in the STARS weight. So historically, there were 5 measures for HOS. 3 of those measures single weighted, right? So that's your bladder control, your physical activity, and your fall risk. So those are all single weight. There were 2 triple weighted measures, improving maintaining physical health and improving maintaining mental health. And so CMS actually changed the way that they wanted to calculate those 2 improving or maintaining measures. So during that time period, they took them out of the star rating, put them on display, and that's kind of where they sat for the past couple of years. So when they did that, HOS went down to 3% of the overall star rating for plans. I mean, as a leader, you're trying to focus on where do I prioritize? What do I put my resources into? Where do I put my funding? And 3% just, it wasn't enough to really justify supporting all of their attention towards HOS. But this past year, 2026 star rating, those improving maintaining measures, they return to stars. And when they return at a one-time weight. But plans are able to see their performance. They're able to see where they landed on stars. And because that took a back seat, I think, they didn't come in exactly the way that people have hoped. So all of a sudden it's like, oh no, I'm not performing well here. For 2027 stars, these measures are going to go back to a 3 times weight. And what does that do? That changes it to 12% of the overall star rating, which now that's significant. So people are, spinning their wheels like, what are we going to do to get a strategy in place to improve these improving maintaining measures in our performance here? And those measures, they're not something that's not one little push campaign. That's not a Q4 push. That's not a survey reminder that's going to change the way you perform. Those have to be a solid year-round strategy. So I think that's where people are starting to focus and starting to wonder, what can I do here?
Let's dig into that. Why are HOS measures, how do they differ from traditional CAHPS or the other clinical measures in STARS, everything else that the plans work on?
Yeah, I mean, that's a great question, because a lot of times plans are just bundling, they just say CAHPS HOS, like it's the same thing, because they're both surveys, but they're 2 very different surveys. They're both perception surveys, but CAHPS is a perception of experience with the plan. So it's their experience with customer service, it's their experience with accessing care, it's their experience with getting needed prescription medications, for example. So very close to what they've actually experienced with the plan. And I think even more different are the clinical measures that you just brought up, because they are all about documentation. They're all about closure, specific outcomes. So you've got a set number of members that qualify to go in your denominator. You know exactly which members you need to tackle, which members you need to get that documentation to close that gap to meet your goal. So you really know where you stand at different points in the year. Where HOS is, it's different, right? Because again, we're coming back to a survey, a perception-based survey, But now we've got perception of our health status, right? Our physical health, our mental health. And it's not what a doctor has documented about their physical or mental health. This is how they perceive themselves. And these improving maintaining measures, they're very different because they're actually what they call longitudinal measures. So they measure members over a period of time. So the way that works is members receive a baseline survey, and it asks them, a series of questions around their physical health. How would they rate it? Does it affect their activities of daily living? Same with their mental health. And they can come in and rate that. But that actual baseline survey isn't the plan star rating. The plan derives their star rating when a member gets the same survey 2 years later, and they're asked those exact same questions. And the plan has to maintain the way that those members responded to the survey 2 years ago, right? So if they said, their physical health is fair, their mental health is fair, and then they get this follow-up survey and they say it's poor, that's where you're losing your points. That's where you're losing your star rating. And you think about this population we serve, 65 plus, a lot of plans have members that are, in that 75 plus range with lots of comorbidities. It's hard. It's really hard to impact that. So, and again, it's their perception. So that's the message you need to get across to the members is, even if they're improving, you need to make them realize that they're improving in their health status.
That's actually a really interesting point because there's so many moving pieces. You have, if you look at the member itself, because we're talking about seniors, naturally for some segment of that population, their health will decline. And so maintaining is a high bar. And when it comes to maintaining, forget improving, maintaining as a minimum requirement, that's a high bar. And then there's recall. You may have a program put in place in the year one, you may have one outreach, but not doing that. And not only doing it, but remembering at the time of the survey and the response whether the member can connect what you've done or the provider said back to the measure.
Totally. And I think that's a great point, the recall piece, because so I focus on those improving measures, but like when you look at those HEDIS effectiveness of care measures, granted they're one weighted, but that's what it's about, right? If these members are brought into that denominator, say they're at risk for falls, right? Did their provider advise them on falls? And they may have. That could have happened during the visit. The provider could have submitted some kind of code saying we did a whole fall assessment. If the member didn't remember that and they say no on that survey, that's what counts.
Right. And you're somewhat looking at smaller samples. Is that correct compared to CAHPS, or is it a different sample size because it's the same member twice?
So it's a larger sample. When we talk about CAHPS, the sample size, standard sample size is 800 per contract.
Right.
When you get to HOS, it goes to 1,200 per contract. But I will say, to get a member to follow that survey over the course of 2 years, by the time that we get to responses, we're down to 200-ish members for a contract that's representing the contract. And that's hard too. And CMS actually just changed the requirements of those improving maintaining. So if plans don't receive 100 responses, they're not even eligible for a star rating in those measures. So responses are important.
So that drives home the point that your CAHPS strategy could not necessarily easily transfer to your HOS strategy. And so how do you see plans working with HOS versus some of the other approaches? What's hard? What's different about HOS compared to the other strategies they have for CAHPS and others?
Yeah, so CAHPS, I think you've got more data feeding in, right? I feel like there's a lot of different listening points that you hear from members. You've got grievances, you've got call center data coming in. A lot of plans have mock CAHPS surveys going on during the year. So I think they're pretty connected to where their performance is, where their pain points are. And a lot of times, it's easier to make that service recovery to disgruntled members. Whereas HOS, it's such a lag in that survey data that you're getting in. Plans just received HOS results, but the HOS results were from 1 year ago, and then taking into consideration, okay, this was the data collected a year ago, but it was over the course of the past 2 years. It's seriously outdated by the time that you get that data. So for HOS, one of the biggest challenge is what can we use internally? What kind of data points do we have? And so many of those data points, at least with clients I'm working with, are super disconnected. I mean, there's just so many ways that data is likely being captured. So you think things like an HRA or an annual wellness visit, maybe even through case management. But are they coding that? Is it accessible? Is it even being leveraged from a HOS lens? They can touch PCP, case management, behavioral health, some of these in-home programs, and that data is all collected, but just rarely aggregated in a way that's meaningful for HOS. You know what I mean?
Yeah, that's a great point. So they do have a number of solutions or approaches today. What do you think that needs refinement or doesn't work easily for HOS? So just let's take one example of what they're applying in CAHPS that may not work for HOS.
I think with CAHPS, there's a lot of like last minute campaigns or Q4 pushes to remind members to respond to a survey. But for HOS, like it really can't be just a campaign. It can't be a short term, not tailored to specific needs or risk for members. It really, those types of messages, it's health related, right? It needs to be relevant for the person that it's going to. So, I mean, the lack of year-round programs, being consistently built into outreach that's already happening, whether that's through case management, through pharmacy. I think that seems to be a big thing that's not working for HOS right now. I hit on it too. I don't think they're fully leveraging the data that they already have. And even if they're building predictive models or assessments, if that's not being shared with teams and integrated into things like CM, or even customer service, that's a huge missed opportunity in my opinion.
That's great insight. It now leads to the next question: is if you had to break it down, what are the three things every plan executive should prioritize when thinking about HOS if they want to move the needle across next year, across the 2 years?
Yeah. So I think collecting the right data, leveraging that right data to flag your members that are most likely to experience those negative outcomes. You want to prioritize members that carry the biggest influence, right? And you got to prioritize them by timely personalized outreach. So that could be through case managers, that could be mailers, it could be digital. Like a lot of members now, that's how they prefer to be contacted. You want to respect their communication preferences. So some it's best with text, others might be best with a phone call. But the goal is really to funnel those members into the right level of engagement based on their need. No more of the one size fits all, because I think that's where plans are falling is like, I'm just going to do a fall risk message for all my members, or I'm going to push out let's increase physical activity and to members that may be wheelchair bound and it's just not even appropriate. I also think, like I said, integrating that data into your front line. So your care management, your customer service, your in-home vendors, you want to train them on how to like really reinforce those positive health behaviors and that perception. And that can just be done through phrasing too. So like if they're talking to them and there is progress, highlight that progress during that conversation so they realize they are improvement, or reframe challenges into something that might sound like a little more positive to that member. I think on the flip side too, if you've got customer service and they're talking to a member who sounds upset, sounds kind of lonely, isolated, depressed, or like they have physical limitations, being able to identify that and identify like a next best action for that member and that would benefit from support. It could be, fall risk assessment, and it could be a customer service sending somebody to case management who might have not already been in case management. But I think being able to trigger those follow-ups is huge. And I think the third piece, at least that I see that it has been super important, and I think plans are good at it in other areas of STARS, is really around provider engagement and incentives. So, I mean, a lot of the incentives are very HEDIS heavy, adherence, really wanting the provider to work with them to close gaps. But a lot of the times that left out experience and outcomes. So I am seeing more plans move towards building CAHPS into their provider incentive program, whether it's through a mock CAHPS or using just their overall CAHPS values to reimburse those providers for performance. But rarely am I seeing HOS. That's an area that plans need to go. What plans really need to consider is, really engage those providers around HOS. And it doesn't have to be a mock HOS survey. What it can be is more around engaging providers to drive behaviors, whether that's through referrals. Like you could have providers that, you're incentivizing on the percentage of members that they screen for, I don't know, depression, right? And then of those members that were screened from depression, how many of them were referred to behavioral health? And was that loop closed? Did those members actually contact behavioral health and go through that visit? I mean, that could go to SDOH, community needs too. Were they referred out? Did they close that loop? But I see the plans that are performing well and moving in the right direction in HOS, that's what they're starting to incorporate into their value-based arrangements.
That's really insightful. In fact, it seems like a combination of roles, the provider action plus vendors plus the plans leadership on this. Where have you seen some innovation and promising practices where these all come together?
Yep. So going outside of like a mock cost survey, incentivizing the providers on making those referrals and driving action, that's one of the biggest ones I've seen. Some other really neat things are working with providers on closing equity gaps. So if they're seeing disparities in their HOS data, working for them to close that gap with those members. So really drilling in on, HEI and just needs that aren't being met, because there's going to be provider groups that have big populations for those members, right? So being able to incentivize on, maybe you went from a 5-point disparity for that member group to a 3-point in your practice. Maybe that's an added bonus for you, for doing that, which I really like looking at HOS through that lens. And then I'm actually working with a client who is testing this right now, and it seems really promising for HOS. They're exploring a lot of the community-based partnerships. So within like their local markets, working with like a YMCA, the senior centers, but actually starting to treat them more like their value-based provider agreements. So actually incentivizing them for reporting, whether it's attendance, whether they're outcome tracking in there, or based on their own outcomes that they're seeing in HOS, if there was improvement, going back and rewarding those groups for being that partner, and for prioritizing their members, which I love.
That's how far along are they in that process?
So because of that survey lag, they haven't been able to see the results. But they're about a year in, and honestly, the community groups have been very open to it. And to get that started, they've given them just different, I don't know if grant is the right word, but like a sponsorship almost, to help expand their resources, help give them the support that they need for the reporting, and just continue to keep them engaged. I mean, members are super open to it. The providers are referring right through those programs. I think we'll see some really positive results when HOS comes back out.
Yeah, it seems like it's not just a one and done. You really have to think about that entire. There's a herd, there's a community that really can assist the member in driving HOS programs forward.
Exactly.
So if you could wave a magic wand and fix one systemic issue holding back HOS performance we see this across all plans, what would it be?
It's a great question. I think one thing, at least as I work through some of these, best practices and getting providers involved and getting CM involved, like one of the barriers is not being able to see if referrals have that closed loop. So I think if I could wave the wand, it would be them to have visibility, whether it's through the EMR or the CM system, to say once they've referred out, or once case management has connected them to behavioral health, what's the easy way of seeing that happened, that the member's connected, the member went through that resource without them having to call, without them having to chase faxes, go through a million different systems to see. I think just seeing that action is actually taken would be huge, because it's not the recommendation that's going to be meaningful when members are responding to HOS. It's the action, right? Like, are they getting the help that they need?
Have you seen any innovation or work done on helping members recall the help or the action that they've taken? Because 2 years is a long time. People may not connect something that the doctor said in a visit or the provider said in a visit to the HOS survey, when it comes out a year later or 2 years later.
Yeah. And I mean, that comes back to just leveraging your data, right? So if you've got the member going through their annual wellness visit, and those are topics on the annual wellness visit, as HOS is approaching, why not send them a reminder? Like, you have the claim from their annual wellness visit. They talked about this with their provider. Like, send them a mailer to say, thanks for being proactive with your health, getting your annual wellness visit, discussing these important topics with your provider. And I think just working internally too, for any of those frontline teams, to continually build that like HOS friendly centric language into everything that they're saying, just so those words seem consistent, right? When the member gets the survey, it's like, oh yeah, maybe they don't even know that they didn't hear it from their provider. Maybe they heard it from customer service or case management. But as long as it resonates, I think consistency is key there.
Right. And that's really very tactical. This actually leads to a broader question of where the industry is. Many leaders at health plans are feeling stuck between the margin pressure that they have right now. So Medicare and the margin and profit in Medicare versus the quality improvement efforts around stars and quality and HOS. How does that tension show up when you're looking at HOS and looking at some of the other very specific measures here?
This is a big pain point for me, I think, and for many plans, because all of the things that you're offering that would impact HOS, like you have the benefits there, right, to support HOS. But a lot of times, then you've got actuarial teams who are like, no, 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 we don't actually want members to use those. Don't promote those. And it's like, you need them to see the bigger picture because the money up front is nothing compared to what you're going to reduce down the road. So, like ER admits, hospital stays, surgeries, like you're going to pay for that in claims if you're not paying for it in a benefit that's a much lower cost. So, really trying to get them to see that big picture, like ROI, this is worth it, right? If you can get members into your silver sneakers or your silver and fit, and improve physical activity while you're helping HOS, but you're helping a lot more too, right? So I think, and even like OTC. So like a lot of plans like struggle, like what can we do for urinary incontinence? You know, it's such a taboo topic. It's hard to talk about, but I mean, the reality is many members struggle with that. So when you have OTC items and you feature those for incontinence, you know, that helps the members, right? They're going to utilize those benefits and they're going to recall that as they take the survey. But back to my pain point is like, so many times they're like, we just don't want to promote the benefits. Like, we don't want to use too many. But I mean, you have to. If you want to be successful, you have to.
Right. And HOS is here to stay. It's reprioritized. It's coming back as a measure, and it is high weighting. Actually, question for you: where do you see the future of stars and HOS going in the next 3 to 5 years?
Yeah, I mean, HOS is here to stay. That's for sure. If anything, I think it could potentially even be expanded, right? So we've got the PFADL measure sitting on display, which is that physical functioning activities of daily living. So that's really going to dig into all of the activities of daily living for members, you know, if that's limiting them. But that's been sitting on display for several years now. And there's talk about, you know, when is that going to come into the picture? Because that'll also be a longitudinal measure. So again, increasing the importance of HOS in the overall star rating. So something plans, you know, if you're not thinking about it, should be thinking about that, right? And as you're talking to providers and starting to build that incentive program, just act like it's a measure, you know, already start to incorporate that. So providers are ready for it because it's coming. I can also see like the administration right now is the mail and the phone administration, and we saw CAHPS move to web. I could see some of that starting to come into play. I'm not sure why they didn't do it this year. It's strange to me that they didn't just keep them together, but you know, that's how it works. So I could totally see that moving to web modality. And I mean, honestly, that should help with response rates, right? Anytime you can take a survey online, I would take it online.
Right. And the demographics are changing as well.
Absolutely.
Technology literacy. So that actually raises a point. For health plans listening today, what's the one takeaway that you'd want them to remember when tackling HOS measures?
The one takeaway is cannot be a last minute play. It cannot be just cast that net with a message and hope you reach all members. HOS has got to be year round and it's got to be integrated. I mean, you're going to need all hands on deck. This is not just a clinical play either. You've got customer service, you've got CM, you've got BH, you've got so many different teams, provider groups involved in here. Really establish yourself a governance, establish yourself a year-round strategy, and any outreach that's already happening, just start to integrate that, right? Like know who your members are, what level of touch your members need, and keep that consistent. Because when we're working over a 2-year period, just a one-time a year push, that's not going to change their mental health status. That's not going to change their physical health status, right? And this isn't just for HOS. I feel like HOS is like central to all of those stars measures, right? I mean, your health outcomes, like if you think through CAHPS, those members that rate themselves in poor mental health, poor physical health, every time I see segmentation reporting, those are the members that are also responding poorly to CAHPS. Those are the members that aren't adherent. Those are the members that aren't closing their gaps. You're hitting on the right members by keeping this just a continuous strategy.
That's great. It really gets to the root cause of a lot of what we do at quality improvement. So thank you for that. So with that, Heidi, thank you so much for joining us today. And for the listeners who want to learn more about your work and what you do at Rex Wallace, how can they reach out to you?
Yeah, you can reach me through LinkedIn. You could shoot me an email, heidi.salerno@Rex Wallace Consulting, and happy to help you.
Super. With that, we'll wrap up today's episode, Problem Solved. And hope you all enjoyed the conversation. And thank you so much, Heidi, for joining us. And look forward to the next one.
Thank you.